And Dr. Scarlett, you're up, and Dr. Scarlett will be giving us the BIA-ALCL update.
Good morning, and thank you to the committee for asking me to do this update. I have no disclosures as it pertains to this, but I will say as a plastic surgeon, it's a rarity that I get to put together a lecture that doesn't have before and afters. So it was kind of nice to be able to review the slides on the plane without offending the person sitting next to me. So let's dive in. So I throw up this history slide really just to show the interval between when the implant is placed and where we're starting to see this ALCL develop. So the first case was reported in '97. We started putting the textured implants in 87. So again, that falls into that 7 to 10 year time frame that we see this develop. We talk about microtexturing and macrotexturing. And again, there's the definitions, but the reality is that the FDA came out with their Class 1 recall in 2019 for the macrotextured implants. And I make this point because microtextured implants are still being used worldwide. It's just the macrotextures. I also point out that this is a Class 1 recall. So the FDA is only recommending removal if the patient has symptoms. So when that patient walks into our office and they say, I had a breast augmentation for cosmetic reasons in the 80s. I, of course, can't remember who the surgeon was. I can't remember what hospital it was done at, which always kind of boggles my mind. But I'm pretty sure that they were textured implants. In fact, I'm 100% sure they were textured implants. According to the FDA, there is no recommendation to remove this implant. So if that person is highly concerned, the insurance company's not going to cover it. So again, it becomes an issue. Now with our reconstruction patients, it's not an issue. Whether they know, whether they don't know, if they're concerned, we can always change out the implants as a revision. But if it's a true cosmetic case with this Class 1, it does not mean that we'll be able to remove it. So presentation, 70% of these cases show up as a unilateral seroma. Most of us probably knew that, but 20% of these cases present as a breast mass and therefore will require a biopsy. 5% can just show up with lymphadenopathy, rash, pain, or a tightening of the implant itself. So if we do an ultrasound and there is fluid, we send it for CD30 cytometry. But we need to note, we need greater than 50 cc's of fluid in order to make this diagnosis. So if we just pull 10 or 20 cc's and send it, they're not going to be able to do this test for us. So it really needs to be quite a bit of fluid that we're sending to pathology for review. Now, we're obviously not going to go over this, but just know the NCCN guidelines are available to us. They dictate everything that they want us to do as far as the workup and the diagnosis. The only thing I'll point out is if when you've aspirated the fluid and you've sent it to pathology and they've done flow cytometry and it comes back indeterminate for lymphoma, their recommendation is that you then send it to a tertiary cancer center to have their pathologist look at it. This is something that the more experience you have looking at this, the better off you're going to be to diagnose it. And we have had some cases that kind of the retroscope, we've looked back at some of these and we said, yeah, that was kind of missed early on, unfortunately. Treatment. Again, this is the NCCN guideline, but it is typically complete removal of the capsule with a normal tissue margin. Okay, you'll hear some of my colleagues talk about en bloc resection. That is incorrect. As we all know, that's just removing the whole thing in one piece. What's important is getting rid of the entire capsule, but with the normal tissue margin. That can be really difficult on that posterior aspect of the chest. It's sitting right on top of those ribs, and that 90-pound patient, you may want to have thoracic around just in case you're getting a little too deep. 1 in 8 patients may need additional treatment. So even though they've had complete surgical resection, they may need chemotherapy and or radiation for their treatment. So I mention this because it's important that we get our oncology colleagues involved and sometimes our radiation. So this is a great case that we want to make sure we're presenting at tumor board, and sometimes we even need to reach outside of our own institution to find out what would people who've seen more of this recommend in this case. So what do we need to know? This is still a very rare disease. So this is the January numbers that in the US, cases, 428 cases have been registered. Worldwide, 1,355. Now, I will immediately say I think this is underdiagnosed. There are certainly plenty of places that people are going in, removing kind of a cruddy-looking capsule, but not sending it for diagnosis. Fortunately, if they remove the whole thing, the majority of the time they've taken care of this patient, but it doesn't then show up in the registry. The FDA is recommending that an ultrasound and or MRI be done 5 years after the placement of an implant, and then every 3 years, one of these two. I can tell you that in the cosmetic world, this is not being done, but just remember that this is what the FDA is recommending. The flow cytometry that needs to be done for this can be done at any lab. This is not a specialty test that has to be run somewhere at a more complicated lab. But remember, we've got to give them 50 cc's at least for them to be able to run this. I throw this up just so that you know there's a lot of people working on this. There's NIH, NCCN, the American Society of Plastic Surgeons has actually teamed with the FDA and put together the profile registry. And the reason is that this is a very rare disease that we don't quite understand. We don't know why is it that macrotexturing versus microtexturing makes a difference. Is this a biofilm? Is this an infection? Is there something else going on here? And why is it taking 10 years to develop? So there's a lot more data that we need to gather in order to completely understand this disease. And there's multiple institutions that are trying to look at this for us. So in summary, we need to know whether it's a macrotextured implant or a microtextured implant. We need to look at the fact that it's 5 years to 10 years in place. Now, does this mean that if somebody shows up in my office and it's only been in for 3 years and they've got a unilateral seroma, that I'm not going to send it for flow cytometry? Absolutely not. Just know that on average, it's 5 to 10 years that this develops. If there is the seroma, you do the ultrasound and the aspiration. If it's a mass, it's your standard, core needle biopsy. I will say that especially depending on where you are in the country, you may want to let your pathologist know that this is a concern. Again, that retroscope with a couple of cases we've looked at, had we let the pathologist know that we were concerned about this, I think they would have looked at it a little differently as opposed to just, is this ductal carcinoma or not? The flow cytometry, I know I'm beating a dead horse here, but 50 cc's at least, which again is a lot of fluid that we've got to collect and send, and then we don't completely understand this. So it is a rare disease. So if I had somebody present to my office who is 80 years old, who had a macrotextured implant with no symptoms, and they said, should I have this removed? I would absolutely not take that person to the operating room. But certainly if someone's in their 30s or 40s or 50s, I would be much more apt to take them, one, in order to send the capsule and make sure that we're okay, even if they have no seroma and everything looks good, but two, to put their mind at ease, because certainly the more we learn about this, it continues to come up in the media, and there is that concern for the individual. So we need to treat the patient, but we got to realize that this is really an evolving diagnosis, and we're going to continue to learn more about it as we get more data into that registry. That's it. Thank you for your time.